Hello, I am Leslie Appiah, and I am the Director of the Fertility Preservation and Reproductive Late Effects Program at the University of Colorado and Children's Hospital Colorado. I have the pleasure of sharing the goals of our program with you and how to request consultation. In 2019, there were approximately 1.7 million new cases of cancer diagnosed in the United States. Of those, over 10,000 occurred in pediatric patients ages 0 through 14 years, and almost 70,000 occurred in the adolescent and young adult population ages 15 to 39 years. Due to early detection and newer targeted agents, 5-year survival rates have significantly improved to 85% for youth, with an estimated 100,000 survivors of reproductive age annually. Consequently, 75% of survivors will experience at least one adverse effect, termed late effect, of cancer therapy. Studies of 1,700 childhood cancer survivors show that 12% of girls receiving at-risk treatments will experience primary ovarian failure, and 66% of boys will experience male germ cell dysfunction. Other significant late effects of therapy include genital graft versus host disease after allogeneic stem cell transplant, radiation-induced uterine and vaginal injury, and sexual dysfunction. Alkylator and radiation therapies confer the highest risk to fertility. Therefore, risk stratification is based on these therapies. The cyclophosphamide equivalent dose score is a calculation used to compare different alkylator therapies. Age confers protection in females. Therefore, prepubertal patients can tolerate higher doses of therapy and retain fertility than postpubertal girls and adult women. For example, pubertal girls who receive 8 grams CED are at the highest risk of infertility compared with prepubertal girls who receive greater than 12 grams of total alkylator therapy to achieve a similar risk. To address these concerns, national governing bodies in oncology and reproductive health develop position statements to guide how we should care for this population. The guidelines assert that providers should inform cancer patients about options for fertility preservation and future reproduction prior to treatment, and that this should occur regardless of age, gender, culture, socioeconomic status, or healthcare team bias. Despite national guidelines, less than 50% of patients with cancer recall discussing fertility risk with a healthcare provider, and less than 30% of those patients go on to receive fertility preservation therapies. Most of the attention in the field of fertility preservation has been placed on patients with cancer because of the devastating effects of therapies. However, other populations that benefit from fertility preservation include patients with non-malignant disorders treated with immunosuppression or stem cell transplant, such as patients with systemic lupus erythematosus or sickle cell disease, individuals with gender and sex diversity, and patients genetically predisposed to accelerated follicular loss, such as patients with Turner syndrome or Turner mosaicism. The Fertility Preservation and Reproductive Late Effects Program addresses current gaps in care. Our team may be consulted in the inpatient and outpatient settings 7 days a week via Epic, the OncoFertility pager, or our dedicated fertility preservation email address. We see patients from birth through age 42 for females and through age 50 for males at diagnosis who are having planned removal of a gonad and/or chemotherapy, radiation, or surgical procedures that affect fertility. Fertility preservation options discussed include both standard and investigational therapies for males and females, pediatric, and young adults. Mature egg freezing, sperm banking, embryo freezing, and ovarian transposition and shielding during pelvic radiation are all standard of care therapies with varying degrees of success. Investigational therapies include freezing immature eggs and testicular tissue, as well as providing hormone suppression for ovarian protection. The investigational label on ovarian tissue cryopreservation was removed December 2019, and ovarian tissue cryopreservation is now considered standard of care. Testicular tissue freezing is still investigational in the prepubertal male. Reproductive health care and survivorship includes evaluation for late effects such as hormonal insufficiency, risk of adverse pregnancy outcomes, genital complications from stem cell transplant, and sexual dysfunction. We also address immunization schedules and breast and cervical cancer screening. You may learn more about the program by visiting our website. Thank you for your time and attention.